Hello guys, let's discuss this fundus image with respect to the clinical scenario that is mentioned here, which is about a 45-year-old male with a history of hypertension and hyperlipidemia, with a history of amaurosis fugax in the left eye over the past 2 weeks, and we've been asked to identify the clinical finding marked, right? So first of all, which side fundus is this? As I always tell you, the optic disc is located nasally, and we've got the temporal vessels enclosing the macula, which is located temporally, right? So this is the left fundus, and I also get a clue from the question which says there's a history of amaurosis fugax in the left eye. So definitely this is left eye. Now one more thing that I want you to understand here, look at the ratio of the arteries and the veins. See, this is the artery and this is the vein, which is a little darker. Now, the normal AV ratio is 2:3. If I consider artery as 2 parts, the vein would be 3 parts. But here, I see that there is arteriolar attenuation. It's a little more thinned out, which is a feature of hypertensive retinopathy. So, there is arteriolar attenuation that is here, which is grade 1 hypertensive retinopathy, generalized arteriolar attenuation. Now, what is this amaurosis fugax? Amaurosis fugax refers to transient visual blackouts. Now, why is that going to occur here? Now, let's come back to the fundus image. Now, this bright yellow finding is Hollenhorst plaque. Now, what is this Hollenhorst plaque? It is a cholesterol embolus. Yes. So this is a cholesterol embolus and this is a Hollenhorst plaque. And Hollenhorst plaque is usually seen in CRAO. But in this patient, the CRAO or central retinal artery occlusion has not yet occurred. But yes, the history of hyperlipidemia suggests that his cholesterol level is high. Yes, the origin of his cholesterol embolus is justified. Now, why would Hollenhorst plaque cause amaurosis fugax, which he's been experiencing for the past 2 weeks? See, when this cholesterol embolus enters into the retinal arteriole, it would have passed through the lamina cribrosa, right? The central retinal artery at the level of lamina cribrosa. There it would have stayed for a few weeks or a few months probably. So it was occluding the retinal artery transiently, and that was resulting in amaurosis fugax. Now it has moved from the lamina cribrosa beyond to this particular point where we can visualize. So in this patient, it has not caused a CRAO. Maybe later it can cause a BRAO probably when it goes and lodges in an AV junction.